Hi, everyone, and welcome to the first deep dive for 2026. It is great to have you all here. We've got about 40 people, so we're going to go ahead and start. And today's deep dive is going to be an expert review by Prof. Wendtner on ASH 2025 Actionable Insights in CLL. I'm going to start with our housekeeping notes. So today's session is brought to you by Blood Assay and Beijing, and in collaboration with Sajas and Sassets. And Prof. Berg and myself, Nicola, and we've got Michaela Brooks, who's helping us with some admin this year. And just some housekeeping notes. So the recordings can be found on our website under Resources Deep Dive. And if you have any questions, you can just save it to the end of the meeting, and Prof. Wendtner and Andrew will lead the discussion. CPD points, you need to attend for a full hour to get your CPD points. When you register, well, all of you would have registered, but it is important that you entered your HPCSA number correctly. If you think that you didn't, just pop us an email at admin@bloodassa.org.za. As your HPCSA number being entered correctly determines if you're going to get CPD points or not. And if you'd like to join the mailing list or update your email or change your subscription preferences, then you can go to our website, subscribe to Deep Dive. And any feedback you have for us at the end of the session would be much appreciated. We use this to feedback to our speakers, tell them what you guys like, what you don't like. And it just means we can keep making this a better platform for all of you going forward. And a note about Heme-Onc, which will be from the 2nd to the 4th of October this year, and will again be at the Century City Conference Centre in Cape Town. The theme for the year is Beyond Boundaries, From Progress to Access. This is the 18th Heme-Onc conference. There is also a physicians conference coming up at the Protea Hotel, and that is from the 4th to the 6th of June, and there will be sessions on hematology. I know Prof. Lowe is presenting there. And from here, I'm going to hand over to Andrew. So the agenda is a talk by Prof. Clemens Wendtner. There'll be Q&A from around 5 o'clock, and then closing after that.
Okay, thanks, Nicole. It's a great pleasure to welcome you all this afternoon to the first deep dive of 2026. We hope it's going to be a very auspicious year for deep dive and hematology education in South Africa. So very privileged to introduce Prof. Clemens Wendtner, who's Professor of Medicine and Senior Consultant for Hematology, Oncology, but as well as Infectious Disease. That's a very interesting, a very useful combination, especially in lymphoid malignancies where infections are not uncommon. And he works at the Ludwig Maximilian University in Munich. So I think he's been interested in CLL for quite a long time, and a founding member of the German CLL study group, and its immediate past scientific secretary, and he's been a PI on many trials. And I think after that short bio, I'm not going to go through the whole of it, but Clemens, we're looking very much forward to your presentation. Thank you.
Yes, so thank you very much, Dr. McDonald, for this kind introduction. And dear colleagues, there are places in the world who wish to be there. And South Africa is one of these places, having freezing temperatures right now in Munich. I would wish to be there on spot, but today we have a virtual meeting. And I hope I can just give you some insights, some news, especially based on the the ASH meeting, the recent ASH meeting, and I'm now sharing my slides with you. Let's see. Should be here. Just a moment. Hope you can see now my slides. And
yeah, we can see them. Thank you.
Okay, thank you. So I will hope to give you some actionable insights in CLL and.
Nee, Jokus moes verskriklik koud en dit reën die hele tyd in Port.
Can we everyone mute
So ek
their,
wil kyk wat's Munich se temperatuur.
can we mute everyone, please?
Ja.
Okay, so I will.
Let me see if I can do that. But yeah.
Fixed. Sorry about that.
Okay, thank you. So here are some potential conflicts of interest. This should be shown as usual. You see some interaction with companies, but well mixed. And now this is the also official disclaimer. So I'm showing here also some drugs that are not licensed in South Africa. But I think this is a scientific meeting, so I will just pinpoint when I'm talking about off-label use. Now, let's now talk about CLL. So we think this is a very unique model system in oncology, especially in malignant hematology. I think at least we have understood a little bit what's going on in CLL, and we know some druggable targets. So anti-CD20 still meaningful. You know that strong anti-CD20s are in use in CLL, like obinutuzumab. BTK inhibitors, it's the backbone of the modern CLL therapy. Ibrutinib, acalabrutinib, zanubrutinib, these are the most frequently used BTK inhibitors. Now, pirtobrutinib, I will also talk a little bit about this in the relapse setting. We have seen new data at ASH also on pirtobrutinib in the frontline setting. Then I think we should mention the BCL2 inhibitors. This is plural because besides venetoclax, there is a new BCL2 inhibitor called sonrotoclax. It's work in progress. It's not licensed so far, but also at ASH, we have seen very interesting updates also on this BCL2 inhibitors. And my educated guess would be that we will see an approval of this drug in the next near future. Besides these classics, especially in the relapse setting, there are trials ongoing. Also here in Munich, by the way, on BTK degraders. At ASH, we have seen some data. Lysocell is a CAR T-cell product that's approved by the FDA, not by the EMA. So this is also something we have to keep in mind. And you don't see mentioning of classic DNA damaging drugs. Chemotherapy, chemoimmunotherapy is, I would say, more or less dead in CLL. It's a field of targeted drugs. Now, what are the guidelines in CLL? And I'm the author of the guidelines of the German-speaking countries. So this includes not only Germany, but also Switzerland, Austria, and some smaller German-speaking areas within Europe. And you see that this is quite simple. We are asking, checking our patients for molecular features like deletion 17p, TP53 mutation, whether they harbor a complex karyotype in their leukemic cells, yes or no. And then if you answer these questions with no, so no high-risk features like TP53 or complex karyotype, we watch out for the IGHV mutation status. And if a patient has a mutated IGHV, we would call him a low-risk CLL. And you see these are the options. time-limited therapy based on venetoclax obinutuzumab, or acalabrutinib venetoclax, or ibrutinib plus venetoclax. You might also use a BTK inhibitor, but for low risk, maybe it's a little bit too much, because BTK inhibitors means continuous therapy if you use them as a monotherapy. Then we discriminate a so-called intermediate risk CLL subtype. These are patients with an unmutated IHV status, no complex karyotype, no TP53, and here we have all options: continuous therapy or time-limited therapy, as mentioned, Ven-Ob, the AV, so acalabrutinib venetoclax, or the IV, ibrutinib plus venetoclax. And on the right side of this figure, you see patients with a high-risk feature, meaning TP53 aberration, complex karyotype. Here we say a BTK inhibitor continuous therapy is the gold standard, and you should think twice when you use a time-limited therapy. So this is the scene given for the CLL therapy. This was the status in September 2025. And in December, usually the ASH meeting comes. And speaking now for the German CLL study group, we had a joint venture with many study groups. You see the Hovens, so the Dutch study group, the Nordic CLL study group, the Israel CLL study group, and so on, Italian, Ireland, Switzerland, and also the Spanish study group. All of them joined to this so-called CL17 project. It's a frontline project. So we had the pleasure and the honor to present data at the plenary session at ASH. And therefore, I think also together with you, I would like to go through some of these data sets, and I think we have enough time later on to discuss details. So what was CL17? So this was a randomized phase 3 trial in previously untreated CLL patients. This was an all-comer trial. As you can see, patients were stratified, but everybody could enter this trial, regardless of fitness, regardless of 17p or TP53 status, regardless of IHV status. So those patients were randomized between monotherapy with ibrutinib, 420 milligram per day, as a continuous therapy. The second choice was venetoclax obinutuzumab, so the standard VO regimen, and the third one was an I plus V regimen. This time, when the trial was started, A plus V, for example, was not approved, and we just didn't have, our statisticians said, also acalabrutinib or sonobrutinib as another arm was not possible, because this would just lead to very high patient numbers we had to screen and recruit. Nevertheless, we had 976 patients screened in 174 sites, or mostly within Europe. You see 13 countries were taking part in this effort. And the enrollment was quite quick. You see February 21 to November 22, so less than 2 years. And this was during the COVID pandemic. So there were some challenges, but in the end, I think all participants, including the patient, made it. So the median observation time for the ASH abstract and the ASH presentation was 34.2 months. And now we can go through some details. So let's first talk about the patient characteristics. You see nicely shared between the three groups. The patient accrued, the median age was 66, 65, so a little bit younger population than we think a CLL patient is presenting. Usually we know that the median age is 72 for a CLL patient, but still we had also elderly ones and also a significant proportion of patients being unfit. So 43% of patients were unfit, defined by the so-called CIL score, the Cumulative Illness Rating Scale score. So if this is above 6 or the creatinine clearance is below 70 ml per min, we would call this patient an unfit patient. More than half of the patients had a so-called unmutated IGHV status, so this is a high-risk feature. And having said this is an all-comer trial, you also see that roughly 8% of patients had TP53 mutation and or a deletion 17p. You see that also complex karyotype was assessed in this trial. 15 to 20% had a complex karyotype within this trial. Now, what about the side effects, adverse events in this trial? There were side effects, especially, let's first concentrate on the venetoclax OB, so the left column. You see, neutropenia was an issue, especially with venetoclax OB. So 52.5% had a neutropenia. This is all great. AFib was less frequent for Ven-Ob, only 3.7%. You see, for ibrutinib plus venetoclax or ibrutinib monotherapy, the AFib rate was above 10%, so 12.5 or 16.8%. And with respect to infections and infestations, roughly 80% of patients had this problem. We have seen COVID-19 infections, especially also pneumonias. And you see some other features like hypertension, etc. But I would like to concentrate now on the infections, because this is still could be a limiting issue also in this trial. You see the venetoclax OB induced, now we are talking about grade 3 to 5 infections. So severe infections, also fatal infections. We had actually 47 patients in the Ven-Ob arm, roughly 16% with a series of severe COVID-19 infection, and roughly 10% had a pneumonia. You can see from these figures that this is higher than compared to the other two time-limited or finite treatment arms. So infections seem to be a problem, especially with Ven-Ob. Now, having talked about side effects, let's a little bit focus on the efficacy of these different regimens. You see, overall response rate is in the range of 85 plus minus %. We have, no surprise, complete remissions, especially in the Ven-Ob arm. We know that obinutuzumab is a very strong inducer of complete remissions, but also the I plus V, so venetoclax plus ibrutinib, is inducing in 46% of the participants in this arm a complete response. Monotherapy with ibrutinib, no surprise, is not inducing a lot of CRs. So the primary endpoint in this trial was progression-free survival, and this was here measured after 3 years. Think about this was a so-called non-inferiority trial. So it's not the case to prove that one arm is better than the other one. It's a non-inferiority arm, and the comparison this trial is powered for is I plus V versus ibrutinib or Ven-O versus ibrutinib. You see the hazard ratio 0.84 and 0.87 with overlapping confidence intervals, so there was no difference. And you see the figures more or less, 80% of patients are without progression after 3 years, regardless whether they receive continuous ibrutinib or time-limited VI or VO. This is, I think, the most important slide from the CLL17 trial. Now we can zoom in a little bit in the subgroups, and just as a co-founder, or just as a remark, this is not powered for. I mean, these are descriptive observations, and what can we say for this subgroup analysis? We have checked whether patients with a so-called unmutated IgHV, is usually a risk factor, are doing worse compared to patients with a mutated IgHV. And you see ibrutinib is neutralizing this risk factor. There's no difference. The same is true for I+V. And we can say that venetoclax-obi has a super appearance in this good risk subgroup mutated IgHV. And so there is not a real difference, but it's just telling us that for mutated ones, VO seems to be, a very good option. So the bottom line is no difference in these three treatment arms, regardless of the IgHV status. But at least from the descriptive level, there seems to be some, some nuances of difference in the outcome with respect to TP53 status. So patients with deletion 17p or a mutation of the TP53 gene, they seem to be performing a little bit worse in the I+V arm, and especially in the venetoclax-obi arm. It seems that the time-limited therapy might not be enough for these kind of patients. The continuous therapy is neutralizing this risk factor. But again, this is a non-powered subgroup analysis, and 3 years of observation is still a little bit short. But if you want to go for a more conservative therapeutic approach, you would offer your patients rather a continuous therapy with a BTK inhibitor instead of going for a time-limited therapeutic option. So this would be my conclusion from this slide. Similar story also for patients with a complex karyotype, and we assessed complex being defined 3 and more aberrations, but we also assessed highly complex, so 5 or more aberrations. Again, the venetoclax-obi, based on just descriptive numbers, seems to be a little bit worse compared to the other 2 arms. You can also see the blue graph here. My personal conclusion for the time being, I would rather go for continuous therapy for patients with a complex karyotype. Now, a very rough endpoint, but the most important for the patients without any doubts is overall survival. And again, Ven-Obi is doing a little bit worse. Based on this number, 91.5% were alive after 3 years, while 95.7 or 96% were alive on ibrutinib or I+V. Why? Because we lost, unfortunately, patients based on infections especially. So 12 fatal infections, 7 out of 12 were COVID-based, and you see the numbers were lower with ibrutinib or I+V. Now, what is the conclusion from CLL17? I think we could say, just thinking about the statistical design, it's a non-inferiority trial. We have to say that Ven-Obi and venetoclax-ibrutinib achieved non-inferiority in PFS compared to the ibrutinib. This was the standard arm. I think we have to closely follow up on some differences I pointed out, but this has to be watched and monitored over the next years. I I think there are some early safety considerations. I think we have to be careful with anti-CD20 antibodies also with respect to infections. Also, the vaccination status is very important for our patients. And venetoclax OB seems not as safe as we might have thought before. We have to be careful not to induce too many infections in these patients, especially in the elderly ones. Otherwise, I think we have to say that the safety profiles are very consistent with known adverse events we've seen before in clinical trials. So what is the meaning for the patients? I think just based on the non-inferiority hypothesis, we can say that for most patients with previously untreated CLL, both continuous BTK inhibitors as well as fixed duration therapies remain very viable treatment options. So this was CL17. You see, spent some time on this trial because we think it might also be practice changing. If you want to read a little bit more about this trial, here's the publication and the QR code, so you can go into details. Now, what has been shown else at ASH? I think we have seen also an interesting 6-year follow-up of the so-called Sequoia trial. So in Sequoia, the second generation BTK inhibitor zanubrutinib has been compared to bendamustine rituximab in the frontline setting. But in this trial, we also have seen 2 arms that have focused on patients with a 17p deletion. So this is just the study design. Arm A and B, so Sano against bendamustine rituximab. Arm C only included deletion 17p patients. And you see Sano monotherapy, and I will just focus on these 3 arms first. And again, it's a frontline trial. In arm A and B, you see 479 patients have been included. In arm C, 111. That's quite a lot for this 17p subgroup. So arm C is unique for this. I think nothing really special. You see, the patients were elderly, so 70, 71 years elderly than we have seen previously in the CL17 trial. And otherwise, you see the risk features, unmutated IGHV. You see also complex karyotype was assessed in the Sequoia trial. Now, the first comparison between zanubrutinib and bendamustine rituximab, you see the upper graph. Clearly, after 6 years, also the zanubrutinib monotherapy was the winner. 74% PFS versus only 32 for the bendamustine rituximab. So the bottom line is continuous therapy with zanubrutinib is not only safe but also efficacious. And I think what strikes me most is also that we have superb outcomes for ultra high-risk patients with a 17p deletion. So 64% of patients were without progression after 6 years. So quite stable data. This is one of the longest follow-up in this subgroup. Therefore, zanubrutinib seems to be a cornerstone for patients in need for treatment with a 17p aberration or TP53 mutation. Now we can zoom in these curves. And again, IGHV mutated versus unmutated. You see, it doesn't matter with zanubrutinib, there is almost no difference, but it matters in the classic chemoimmunotherapy. There you get the spreading of the curves. But I think nowadays we wouldn't use chemoimmunotherapy any longer, at least in Europe. It's no more standard. So we are on the safe way with the BTK inhibitor monotherapy. And in arm C, you can also dissect the TP53 aberrant patients, whether they also have a mutated or unmutated IHV, again, doesn't matter. Same curves, more or less. Now, COVID adjustment, I'm not a big fan of this, but because, this has been also stressed in the Amplified trial for acalabrutinib. Here just the proof that COVID, yes or no, doesn't matter. So the OS curves are not really different. And I think more of importance is other side effects between BR and sonobrutinib. You see that for example, the neutropenia rate with the sonobrutinib grade 3 and more is lower compared to the classic bendamustine rituximab. You see that also pneumonias, for example, they're in the range as with BR, basal cell carcinoma, so secondary skin cancers, also in the same range. So nothing really striking or surprising. I would like to stress as a take-home message for you, for your daily practice, I think Sequoia in the 6-year follow-up we have seen at ASH, we have seen data, especially in patients with deletion 17p. We have seen long-term outcomes, and the data are quite robust. And they just suggest that sonobrutinib can really ameliorate the prognosis in this high-risk feature subgroup. So I think a very safe and efficacious drug, especially in this subgroup. The question was, can we do better also for TP53 patients in the future? That's now not approved. So the question is, when you use a combo like sonobrutinib with venetoclax, can we get out more and maybe even stop the treatment after a while? And therefore, the arm D of Sequoia is also of interest. So 66 patients with a deletion 17p. You see also a TP53 mutation was integrated and was compared to 47 patients without this high-risk feature. They received sonobrutinib and venetoclax. And you see the design, patients were treated first with sano, then venetoclax was initiated, the usual updosing, the weekly updosing you're familiar with. And then based on the undetectable minimal residual disease status, the drugs were stopped. So it's a time-limited approach. You could continue sonobrutinib until you get an undetectable MRD, but otherwise, after cycle 28, the treatment was usually stopped. Now, the disposition of the patients you see outlined here. So altogether, we're talking about 114 patients, so 66 in the interesting arm with the TP53 aberration. As told, also complex karyotype, highly complex karyotype. So you see 36 patients also, 36% of the patients also had 5 or more chromosomal aberrations. And this is the 3-year update of the arm D of Sequoia we have seen at ASH. And just look at the green bars. So this is MRD less than 10 to the minus 5. You see in patients with deletion 17p, we got an improvement from 15% to 38%. So this is, and we are talking about between cycle 15 and 27. So it seems that the longer you treat them, you also get more out of this. And this is just the control arm. Okay, but this argues that these kind of patients also in the doublet might need more treatment, so more than 1 year. And these are the classic PFS curves. I think you would agree that there is almost no difference between patients that harbor a deletion 17p or TP53 mutation and patients without this high-risk feature. So it seems that this doublet can equalize the prognosis and also ameliorate the inferior feature of a deletion 17p or TP53 mutation. Some updates on the side effects and especially side effects of special interest. You see there were some neutropenias, there were some hemorrhages, hypertension, but I think everything we know from zanubrutinib from former trials, nothing really striking when also using a doublet with venetoclax. So altogether, I think we've seen in the Sequoia AMD a 3-year PFS rate of 87% for high-risk patients. This is very interesting and good piece of data, and this is the reason why also the NCCN guidelines in the US now recommend Sano plus venetoclax as a preferred first-line regimen for CLL and SLL. I have to say, officially, this is not approved, for example, by the EMA, but at least you get a recommendation by NCCN to use also this doublet. Now, having talked a lot about CLL17, the Sequoia trial, I mean, there were also other interesting new trial data you should have in mind when you ask what was new at ASH. And this is the trial with pirtobrutinib versus ibrutinib frontline trial in CLL. So this is a phase 3 trial with this non-covalent BTK inhibitor pirtobrutinib, and this is clearly off-label. This is a randomized phase 3 trial. Pirto is only approved in the relapse setting by FDA and EMA. So Jennifer Boyer from the Ohio State has presented this trial. She included treatment-naive patients, but also relapse refractory patients. And the trial was called CLL 314 trial. And also patients with a 17p deletion were included. And this was just a simple one-to-one randomization between Pirto and ibrutinib. The primary objective was a non-inferiority of overall response rate, and in both in the ITT population, so the entire population, and also in the relapse refractory population. You see in the green bar the outcome of our response, 87 versus 78.5% in the ITT population, so the entire population, 662 patients. You see the nominal p-value is 0.0035. You can also recognize this is true for the relapse population, and for the treatment naive, at least there is a trend for a superiority of Pirto. I have to be careful because it's a non-inferiority trial, but it's a descriptive superiority. The same is true for the PFS curves, treatment naive. You see, this seems to be still quite early to see differences, but in the relapse refractory subpopulation, you have the idea that also the curves are splitting in favor of Pirto. I think of interest is now the side effect profile between the two drugs. We do see less AFibs, A-flutters in the Pirto compared to ibrutinib, 0.9 versus 4.0% grade 3 or higher. and especially in the elderly ones, 1.5 versus 7.1%. So this is makes a difference. Now, Perto, as shown in the 314 Bruin trial, is a continuous treatment when used as a monotherapy. So there was an effort by the MD Anderson in Houston, Texas, to integrate the pirtobrutinib in a classic time-limited approach based on venetoclax and obinutuzumab, and this especially in the frontline setting. So Nitin Jain presented data on the so-called PVO regimen. So the PVO trial included frontline patients, and you have to be fit to be treated at the MD Anderson. So this is also of interest when you think about the perspective for this triple combo. And you see many time points where, you know, things like MRD assessment was done, CTs, you see bone marrows, a higher rate of assessments. Thing of interest is now the NGS MRD assessment in blood and bone marrow. And you see the end of cycle 7 and end of cycle 13 data here. And in green, this is not 10 to the minus 4, but 10 to the minus 6. So the highest you can get on the undetectable MRD level. And for sure, bone marrow is always a little bit lower, but still you get enormous high rates of undetectable MRD 10 to the minus 6. After 13 cycles, we are talking about 74%. If you go for UMRD4, it's 96%. So I think this is one of the most powerful triple combos we have seen so far. Still, we are talking about 77 patients, and as told, this is also a regimen, maybe not the best for every CLL patient, especially for frail ones. It's more an interesting perspective for fitter CLL patients that wish to have a time-limited therapy. You see side effects: neutropenia, grade 3/4, thrombocytopenia in 67% with respect to neutropenia, and 70% with severe thrombocytopenia. Fevers have been seen by the colleagues at the MD Anderson. Dose reduction was necessary in 1/3 of patients, and but only few developed cardiac side effects like AFib. So Nitin Jain also summarized and said, okay, we are proud that we have seen these high UMRD6 rates. I think this is of interest, especially after 1 year. The UMRD6 was 86% in peripheral blood, for example, at 74 in bone marrow. And I think we will see more data on this. And they compared it in the internal review to their own data with I+V, for example, and so PVO was better. But it's just a descriptive thing at this point. Now, I think the future strategy is in CLL is to use time-limited therapies more and more. And the question is, when should we stop? And one rational approach is to use MRD guidance as a stopping rule. And this has been also assessed in this trial is called BJP 11417/101. So they use sonrotoclax. This is I would call it a second generation BCL2 inhibitor plus this strong anti-CD20 obinutuzumab. And so these are just phase 1 data. You see the trial design. OB was started, sonrotoclax ramp up, and then sonrotoclax, there were 2 dose levels, were 60 milligram or 320, and based on MRD guidance, treatment was discontinued. Side effects, there is not a big difference between the 160 milligram cohort and the 320 milligram cohort based referred to the sonrotoclax. Neutropenia is an issue, but it seems more or less to be manageable. Some COVID cases, but otherwise nothing, I would say, really striking. Efficacy was high, or response rate 94%, CR rates in the range of 40%, especially with the 320 milligram cohort. And the 18 months PFS rate was 94.3%. So sonrotoclax obinutuzumab seems to be a quite efficacious regimen. And they also assessed by NGS, so meaning a 10 to the minus 6 MRD assessment. So 19 out of 21 patients that were analyzed achieved a uMRD6. So again, this is record high, but still a phase 1 trial. But more to come. There is a registration phase 3 trial, so-called Celestial or CLL trial, that is assessing especially this combo with sonrotoclax in the 320 milligram dosing, and this trial is currently recruiting patients. This is now the bridge to the second part of my talk. It's not the half because I make it a little bit quicker for you. So perspectives in relapsed refractory CLL. This is the German guideline on refractory and also relapsed CLL. You see, everything depends what you did in the beginning. So has the patient received an OB in the front line, then you would rather maybe go for a BTK inhibitor. If it's a late recurrence, you might use venetoclax rituximab. In Germany, for example, once a patient has received BTK inhibitor, second line Perto is allowed. So you see different options in this guideline. In the end, very few patients are eligible for allo. I would say a handful, because we are talking about elderly patients, and usually you have many options before. So what is really new coming from ASH? I would say that we are seeing more and more data on so-called BTK degraders. And so the Cadence 101 trial assessed the role of one of these BTK degraders called BJP16673 in relapsed refractory CLL. Based on 68 patients, the majority with high-risk features, unmutated IGHV, deletion 17p, etc., complex karyotype, many lines of therapy, of prior therapy. We can say the most frequent side effect on a BTK degrader is neutropenia. Grade 3, you see, and more is 25% of patients had this side effect. In some of them, half of them, we also have seen serious pneumonias. Otherwise, fatigue, but not really major grades. So we're using also this degrader within our trials here in Munich. And we are just quite satisfied, and especially our patients, because you got a very quick response and the side effect profile is limited. And it seems that the 200 milligram dosing cohort is the best. This is the cohort. This is also developed for further trials. You see that more than 90%, so 94.4%, are responding. We have to be cautious because this is based on 18 patients in this cohort, but altogether, based on the 68 patients, we have an 85% response rate. And this is remarkable in this setting. The response is observed also in triple exposed patients, so with a covalent BTK inhibitor, with a BCL2 inhibitor, and a non-covalent BTK inhibitor. So 9 out of 12 patients are responding. Also, patients are responding in the complex karyotype subgroup, 72.7%. So the PFS rate after 12 months is 73.5%. So 3 out of 4 patients are still without progression after 1 year, and after 1.5 years, let's say two-thirds are still without progression, so 65.9%. I would like to track your attention also to another CLL-linked disease. I would call it a Richter's transformation. You know that Richter's is occurring in up to 10% of CLL patients, depending on the literature you're reading. But let's say 3 to 5%, I think, is realistic. I think it's important to also know some updates on Richter's transformation. Speaking for the German CLL study group, we have presented at the oral session also an update on the RT1 trial. So our Richter's trial, we have used a combo of a checkpoint inhibitor, tislelizumab, plus BTK inhibitor, in this case zanubrutinib. And we have presented some data before. So the primary endpoint was overall response rate, but for sure we also checked for PFS and overall survival, time to next treatment. And so this we have published, I think 1.5 years ago in Nature Medicine. I think it was December 2024. We've seen a response in 58.3% of our Richter's patients with this doublet. And we have seen 1 out of 5 patients had a complete remission, so 18.8%. This was remarkable, and if you compare it with an R-CHOP, you get lower responses, so less than 40% overall response rate and almost no CR. So this was an improvement. Now we have seen an update with the prolonged observation time of 25.7 months. So the median PFS is 10 months, but the 24 months PFS rate is still 33%. So it seems that the curves are quite stable at this point, and the 24 months OS rate is 63.3%. Again, we will follow up on this, but at least this 2-year view on the data is promising. I think it's better than R-CHOP. Therefore, in Germany, I would say most of the Richter's patients are now treated with this doublet instead of R-CHOP. So there are updates on this protocol, this RT protocol. Right now, there is a triple combo evaluated. This triple combo includes also BCL2 inhibitor, in this case sonrotoclax. But this is an ongoing effort, and there are no data available at this point. So I would like to summarize the data I've shown you based on the recent ASH meeting. I hope you could appreciate that the CLL17 trial, abstract number 1 from this year's ASH, has shown that a time-limited therapy based on Ven/Obi or ibrutinib plus venetoclax is the same more or less than a continuous therapy, so it's non-inferior. I have highlighted that high-risk CLL, especially patients with a complex karyotype, also patients with a deletion 17p or TP53 mutation, might benefit more from continuous therapy. But again, this is under investigation. We have to look for the data based on a longer follow-up, so more than 3 years. Sequoia, there were 2 abstracts dealing with zanubrutinib monotherapy or sano plus venetoclax, so arm C or arm D from the Sequoia trial. Arm D, I have to stress, is off-label. But in summary, sano alone or sano plus venetoclax is highly effective in patients with deletion 17p or TP53 mutation. The Bruin 314 trial, a frontline trial, has shown that pirtobrutinib in general seems to be is at least non-inferior compared to ibrutinib. So this was the statistical design of this. On a descriptive level, we've seen better data for pirto compared to ibrutinib with respect to overall response rate, PFS, and toxicity. But at this point, pirto is not approved for frontline. I've shown you the MD Anderson data of the triple combo PVO. So pirto, venetoclax, obinutuzumab. We've seen extremely high UMID6 rates, up to 86%. This is based on peripheral blood, but again, this combo is not approved. And I've shown you some data on the second generation BCL2 inhibitors on sonrotoclax in combination with obinutuzumab. The UMID6 is up to 91%, so one of the highest we know. Based on peripheral blood, cycle 15, again, it's not approved, but I pinpointed to clinical trials, especially the Celestial trial, that is elaborating this combo more and more. Now, within the relapse setting, I would say the greater trials of interest, I just picked one, the Cadence trial, because I think it's one of the most advanced trials in the setting. We've seen in this refractory setting response rates up to 94%, especially in the 2 milligram cohort, and PFS rates after 1.5 years of almost 66%. I've shown you an update on the RT1 trial, the Richter's trial, based on the tislelizumab and zanubrutinib, with, I think, good outcomes with respect to PFS and OS. Formally, on a formal point of view, it's an off-label standard, but I think it's worthwhile to just convince also health insurance companies to pay for this combo, because I think it's much better than a classic R-CHOP. So having said this, I would like to thank you for your attention. Here are my contact details if you want to ask questions after the seminar. And otherwise, I'm stopping now, and I'm happy to answer some questions you might have. Thank you.
Thank you very much, Prof. Wendtner. So there are currently no questions in the chat box, so I'm going to start with some questions. You've indicated importance of complex karyotype, and you've also incorporated it into your guidelines for standard clinical practice. So no, we don't have CLL karyotype routinely available to us. So the question is, how important do you think karyotyping is in the assessment of CLL? And this also in terms of CLL 17, what was the percentage of successful analyzable karyotypes in CLL? I mean, because there are always going to be patients who don't grow. So do you know that data in terms of how effective is karyotype?
Okay. Yes. Thank you, Dr. McDonald. I think a very important question. So there were years where we thought that things like complex karyotype translocations are not very important for CLL, and also the technique was underdeveloped. Also, my research group, we just focused some years ago on this, And by using either CD40 ligand feeder layer assay, or much more simpler, just CpG oligonucleotides, you can get good karyotype assessment in 90% plus of your CLL patients. So the technique per se is nowadays well established. And now, in answer to your question, we do see in roughly 14% of patients a complex karyotype independent of a TP53 aberration. So we would miss this when just assessing, classic FISH and TP53 screening assays. And so the new German guidelines, I didn't highlight at this point, also said that the assessment of translocations would be desirable. It's not mandatory at this point, and we know that translocations are also another high-risk feature. We know that up to 30% of CLLs have translocations. Not all of them are, so we have to discriminate them between balanced and unbalanced translocations, etc. But again, it seems that there is also another high-risk feature behind this classic assessments. And so in Germany, we are saying, okay, complex karyotype is meaningful because it's not only an academic thing, but based on CL17, I've shown you that a time-limited therapy, at least based on Ven-Ob, may not be enough for these patients. So again, a more continuous therapy might be more beneficial for these patients. That's my answer. I appreciate, or I'm recognizing that these kind of assays might be expensive and not be available in every country. But I'm just saying we would rather recommend a continuous therapy also for patients with a complex karyotype, at least a highly complex karyotype.
So just following on, there's now a question that's appeared. So, I mean, what do you consider as a baseline investigations for CLL treatment decisions? So you've indicated on complex karyotype, but there's a question. I mean, it's from someone who works in a very resource limited. I mean, the access to any novel therapies are predominantly doing chemo or chemoimmunotherapy.
I mean, I would say most important is at least to assess TP53 aberration. I would be happy if I do see at least a FISH. The 17p deletion is then excluded. I mean, would be better also to do a TP53 sequencing, but I mean, if the resources are limited, I would be happy at least to see a FISH on 17p, because this triggers a treatment decision, TP53 patient, I would rather give a BTKI monotherapy or at least an I+V. I would not give, or no, I would not offer Ven-Ob nowadays. So I would say this is something I would recommend. The IGHV mutation status, we can say, I mean, does it really matter after CL17? I mean, we've seen that regardless of the IGHV mutation status, either one of the three regimens we compared is equal. So you can use ibrutinib monotherapy, you could use I+V, you could use Ven-Ob in an unmutated, IGHV unmutated patient, and it's still more or less the same. So this is something, if resources are limited, you can neglect, but at least 17p deletion should be excluded, I would say.
Okay. So the question, so you indicate in CLL 17, 17p disruption in whatever form it takes, best served by continuous BDK inhibitors. But the Sequoia Arm D, the Zanu plus venetoclax, actually had a very good progression-free survival. So do you think, I mean, because in that study, the BDK was prolonged greater than the usual standard time-limited, like I plus V, kind of option. So do you think that is it possible to do time-limited therapy? Because obviously long-term BDK is quite expensive. So is it possible to do a longer time-limited therapy using a BDK like as in Sequoia Arm D? What are your feedback?
Yeah. So in principle, I would agree and say yes. This is a meaningful approach. There are data, for example, for also I plus V. If you prolong it instead of these 15 cycles, or I mean, the combo is only for 12 cycles because you have a run-in of 3 months. If you do the combo instead of 12 cycles for 24 cycles, it's much better for specific high-risk groups. Unmutated IgHV, we have seen in, as you mentioned, the Sequoia AMD, also prolonged doublet. This might be the future also to save some money. I mean, to be frank here, because continuous therapy is not affordable for forever, neither in South Africa nor in Germany, you know. But at this point, we don't know exactly when is the best time to stop. You know, what is the best duration? Is it 2 years? Is it 3 years? Is it 1.5 years? So this is still an open question. If you want to do it freestyle, I mean, and have limited resources, I would say yes, the high-risk subgroups need more than 1 year of a doublet, probably 2 years. This would be my educated guess, but the science still has to be established behind this question.
And then just one last question from me. Obviously, the anti-CD20 addition in terms of infection rates, and I mean, I realize obviously COVID and anti-CD20s are really a bad combination. But in CLL17, just in terms of immunoglobulin measurement and routine replacement, because obviously anti-CD20 is going to, we know CLL has got a high rate of hypogammaglobulinemia, but in terms of adding CD20s to that, and what's your approach to hypogammaglobulinemia in CLL?
Yeah, I mean, I don't know the exact situation in South Africa, but in Germany, we are a little bit limited in the supply of immunoglobulins. It's only reimbursed if you have a level of the IgG below 4 gram per liter. Then the health insurance companies have to support you or the patient, and then it's reimbursed. We have recent discussions with myeloma doctors here in Munich. They do it regardless of the cutoff. You know, they just flush their patients with immunoglobulins. But this is the official rule. If the IgG is below 4 gram per liter, you have to substitute. When the patient also has infections, and I'm doing this here. And in CL17, it was not done because was not prescribed in the strict sense in every center. You've seen we had many centers, and not every center was supplying the IgG. But I mean, COVID was also the COVID problem we've seen. The Van-Obi arm you mentioned was also independent of the IgGs. So this was also on top, I would say. But at least you could maybe rescue some patients or prevent infections in some of the patients when you substitute IgGs.
Okay. So I think there are no more questions. So I am going to say thank you very much for an excellent update in CLL. We can only aspire to some of the things that are happening. Obviously, I know that many of them are in trial situations at the moment, but yeah, it's very exciting to see where CLL is going. And Tremaine, to thank you and to thank the audience, and just to remind you to please complete the assessment, which will pop up when you log off, so that we can just keep track of, and Blood SA can just help us improve this excellent resource. So thank you, everybody, and thank you, Prof. Wendtner, for the talk.
Thank you.